Morning, everybody. Happy Tuesday. Thank you, everyone who's joining. Sorry for the delay. Sonia, are you there?
Yes, I'm here.
Okay, cool. Figured we'll give it like 3 more minutes to allow people to log in, and then we can start with the housekeeping and then just get started.
Sounds good.
2 more minutes, we'll get started. I'm going to be giving a presentation on leveraging social media to bridge health disparities, and then Alex from Johns Hopkins will be joining a little later at around 9:30, and he'll be presenting his complex patient case for us to all give our feedback on. Sonia, if you want to do the housekeeping now, and that way I can start in a minute, that would be great.
Okay. Let me get the slide. I am having difficulties with pulling up the slides. Let me try one other way.
We can just speak to it. It's not a big deal.
Okay, sorry. So yes, couple things, making sure that we are adhering to information, not using any names or any kind of qualifiers. We have our accreditation and EOE statements from UAB, which basically state that we are an equal opportunity affirmative action institution, and that this is designated as one credit. One note to that, UAB is changing our CME system. So the summertime, June, July, August. I think the UAB is not going to have our CMEs updated until September. So just wanted to make sure you're aware of that. But everything was supposed to be uploaded and like converted before the end of May. So also if you don't see those CMEs from prior to May, let me know. And then Maya will go through her disclosures, and I'll put the link for the CME in the chat box.
Perfect. And then Sonia, if you can just give me ability to share my screen so I can get the presentation, that would be great. And while waiting for that, for those who don't know me by now, my name is Maya Bloomberg. I'm a hematology nurse practitioner out of University of Miami. I'm 50-50 between sickle cell and also working at a hemophilia treatment center. And my first week on the job over a decade ago, the disparities were just alarming between sickle cell and hemophilia, and it really kind of just sparked my passion in sickle cell. And through the pandemic is kind of what led me to social media to kind of fight a lot of the misinformation, and it really showed me the utility of us as medical providers. So today's presentation is going to be on leveraging social media to bridge health disparities. Here's a little overview. We'll talk about what is social media. I don't know who is on the call and what everybody's familiarity is, so I'm just going to do a high-level overview. We'll talk about different uses of social media in healthcare, such as for disseminating information or for advocacy. Again, talking about advocacy, and then how to get started if you are interested. So social media really has become an integral part of our lives, and it's changed the way we communicate, how we connect with people, how we consume and share information, and it also empowers individuals like never before. Healthcare providers can use social media to connect with colleagues or share information, stay up to date on the latest research, while patients can use it to find support groups, share their experiences, and just advocate for themselves. Now, the proportion of adults using social media has increased from 8% in 2005 to 72% as of 2014, so we can expect it's even higher now in 2025, and many are using it to guide health decisions. So after today's presentation, you'll hopefully recognize the importance of utilizing social media to reach a wider audience of patients and the general public. So there are various types of social media platforms, and each of them have its own unique feature and purpose. Each type offers different communication and content sharing needs, such as networking or blogging or media sharing, and it allows the individual and businesses to connect, to express themselves, share information, and just engage with people in various ways. Below are the different platforms that all focus on connecting people and building relationships, and they all have users creating their profiles in order to connect, share updates, photos, what have you. So Facebook is a more general social network to connect, and so is Instagram, but Instagram is more of a visual focused platform centered around photos and videos, but obviously we can have different types of posts with content as well. LinkedIn caters more to a business or career oriented audience, and you can create your professional profile, connect with colleagues, showcase your skills or publications, and it's very commonly used for recruiting. So hopefully everybody is happy in their job currently, but if you are looking for different employments, I would recommend making sure yours is up to date and detailed and really highlighting a lot of your accomplishments. YouTube is a video sharing platform, and they have something called YouTube Shorts, which is kind of self-explanatory and offers a similar effect to Reels on Instagram or the short videos on TikTok. Then we have microblogging with Twitter, also known as X or Threads, and this allows individuals to share short form content and real-time update of information and just engage in conversations using hashtags. And just from personal experience, like I used Twitter a lot during the pandemic because I found that I would get information so much faster. It allowed real-time sharing of case rates and updates on different strains, vaccines, and so on. And then lastly, you have the discussion forums, which allow users to kind of ask and answer questions on various topics, and they have specific groups. There is a sickle cell group on Reddit, for example. Now, social media have really revolutionized the way we communicate, and the impact on healthcare can't be overstated. Information dissemination in the medical field, we used to have to rely on the traditional channels like journals and conferences and through our colleagues. But while these avenues still are important, the rise of social media has really democratized access to medical knowledge, has enabled patients and the general public to really take a more active role in their own healthcare journey. It bridges that gap between healthcare providers and the public, and we all know hematology can be quite complex and intimidating, especially for our patients. So for my page, for example, the goal is to create content that is very digestible and easy to understand so they can actually use the information presented to improve their health. The impact of medical influencers extends far beyond just simple entertainment or cosmetic advice. We play pivotal roles in educating patients and empowering them to become advocates for their own health, even prompt individuals to seek more information so they can be informed about their health and well-being. We can help patients connect with different resources and professional health. For just as an example, I've connected countless warriors to NASAC's comprehensive sickle cell centers across the country. My page has helped people realize the importance of mental health and the value of seeing mental health specialists. And then I think my favorite is when my content gets patients to believe providers more than what they read in their Facebook groups, which might have previously deterred them from taking hydroxyurea. Now, there are some considerations when deciding to post information publicly online, which we'll cover later, but this newfound engagement really has the potential to transform healthcare from a passive experience to more of an active partnership between patients and medical professionals. There is a huge uptick in using social media to guide health decisions. A study found that around 85% of participants sought health information using social media, and 28% of participants had used social media for medical consultations. So this highlights that there's no geographic boundaries with social media, and patients can gain access to reputed physicians and medical providers that aren't usually available in certain areas. I can't even tell you, if I got $1 every time, I wouldn't have to work, but I get countless requests for just people requesting consultations from patients in Africa and India, and I turn it down because that is not the goal of my page, also liability reasons, but I personally feel comfortable providing general information. So I feel like I'm providing some help to them and information that they can then utilize, but I also include a disclaimer and say ultimately make sure to speak to your provider. But understanding these numbers, I think our goal really should be to develop connection points between patients and medical professionals and provide access to reliable healthcare advice and resources. Here's another study that found that caregivers are utilizing social media for health information more than non-caregivers, emphasizing the utility of social media specifically for both individuals and families dealing with chronic illness. You can see the most common search are about disease, specific disease or medical problems, or about certain medical treatments or procedures. And while this is online searches, it emphasizes why we need to be strategic with our titles and captions and descriptions for posts and videos, since they're all searchable. The SEOs, searchable. I'm blanking on what the EO stands for, but it is searchable and could appear when a user is performing a search to gather more health information online. And I think that most people don't necessarily appreciate how much strategy there is when it comes to content creation and the hook and the captions, et cetera, when it comes to engaging your community. Many studies indicate that there is a significant percentage of millennials turning to social media as a primary source for health-related knowledge, with one that highlighted that 7% regularly scheduled, with only 7% regularly scheduling preventative visits. So this means that 93% of the millennials are avoiding their PCP. So that means they're utilizing urgent care facilities when getting sick. And this makes, again, online medical advice invaluable since it's an avenue for education and awareness and hopefully can encourage individuals the importance of physical health, mental health, lifestyle, etc. Now, specific to sickle cell, while there's been improvement in life expectancy with newborn screening and penicillin prophylaxis and hydroxyurea, the effects are short-lived beyond pediatrics. We know there's an increase in mortality during that adolescent and young adult years, coinciding with the time of transferring from pediatric to adult care. So knowing this age group is the most likely to use social media emphasizes how having that online presence can directly impact the population's health outcomes. Highlighted here are all of the different uses of social media in healthcare, which I will be going through shortly. With the first one being just the fact it's an essential tool for disseminating real-time information during emergencies, outbreaks, natural disasters. It enables sharing of crucial information quickly, and it reaches a wide audience to promote public safety and awareness. So COVID-19 is obviously the easiest example. Throughout this pandemic, social media played a huge role in disseminating real-time information. We had the World Health Organization, governmental agencies, healthcare providers utilizing platforms like Twitter and Instagram and YouTube to provide updates on case numbers, prevention measures, testing locations, vaccine campaigns, and medical information. And it also became a time to raise awareness about mental health, especially with that isolation of lockdown. Social media was used to disseminate real-time info before COVID, though. So we had the Ebola outbreak in 2014, and health organizations and professionals used Twitter to disseminate accurate and up-to-date information about the virus, prevention strategies, treatment options. And social media played that crucial role in combating misinformation and enabling the rapid spread of essential health guidance. We also see it being used for natural disasters. I mean, I have my personal favorite meteorologist on Twitter that I follow for all of my hurricane information, but it also allows individuals to provide updates with a lot of times end up getting picked up from the news sources to spread awareness, shell evacuation information, or even requesting assistance. Social media has also been proven to be a powerful tool in raising awareness of rare conditions and bridging racial disparities in healthcare. Using hashtags and online communities and viral campaigns, patients with rare conditions are able to connect with each other and share their experiences. And it's not only helped raise awareness of the conditions, but it's also led to the increased funding for research and improved treatment options. It allows healthcare organizations really to kind of precisely target a specific demographic and community for more impactful public health interventions. So in 2014, we had the ALS Ice Bucket Challenge, which became that viral sensation on social media. The campaign had people dumping buckets of ice water on themselves to raise awareness and funds for ALS, or amyotrophic lateral sclerosis research. It garnered widespread attention from celebrities and ordinary individuals participating, such as myself, and sharing videos on platforms like Facebook and Twitter. But the campaign not only increased public awareness about ALS, it raised millions of dollars that went into research and development for new treatments and increasing access to care and services for this population. The Me Too movement started as a way for survivors of sexual assault to share their stories and raise awareness of the issue. It quickly spread, though, across social platforms and led to changes in laws and policies. The Me Too hashtag has been used millions of times in at least 85 countries. Times awarded the silence breakers of the Me Too movement the Persons of the Year, since they had the courage that ultimately brought this huge social change. And you can see down here in the bottom right, there's spikes in the use of the hashtag. So it was first used in January 2016 when Alyssa Milano started the hashtag. And then again, you see another spike when the Times Silence Breakers was announced. And then you see another spike when Oprah addressed the movement in the Golden Globe speech. And this is another reason why there's a strategy when it comes to hashtags. So similar to these public health campaigns, we patients and providers can use social media to raise awareness on sickle cell and advocate for change and improve healthcare outcomes. So we have hashtag sickle cell warrior, hashtag sickle cell matters, or hashtag sickle cell awareness. We have World Sickle Cell Day coming on June 19th. So there's a lot of hashtags, and I encourage you guys to explore and kind of see what's out there. Now, while social media can be filled with a wealth of information, with a click of a button, false information can spread like wildfire, and it's very damaging. It causes, or it has the potential, I should say, to cause harm to individuals who are just seeking accurate medical advice. And the way the algorithm works, it kind of fuels more of the contents that you're seeing. So if you're following somebody who is an RFK Jr. advocate, like they're going to be pushed a lot of information about vaccines and autism and potentially less reliable information. So it's always important to understand the source that you're getting information from. And again, I think this is where healthcare providers really can step in to counteract the misinformation. Like I initially went to social media during the pandemic because my patients were refusing the COVID vaccine because there was so much misinformation out there that it's killing people. It was approved too fast and causing more harm than good. And I wanted to have my patients make informed decisions. You know, I had the entire conversation. I presented them with the science and what we knew, what we didn't know, what the possible risks are. And did everybody get the vaccine? No, but at least they were then, I know, at least they were making an informed decision to decline a vaccine based on reliable information. Now, we know there's a huge level of mistrust among the sickle cell community and medical providers. And I think when providers are active on social media, it kind of helps foster that level of trust so they can value the information being presented. And more importantly, I think it helps warriors realize that not all healthcare providers are bad, because unfortunately, medical trauma is real and it has painted a lot of providers negatively for some individuals. And then lastly, by using social media to share reliable information about healthcare, we're combating the misinformation, and we're just ensuring our patients are having access to trustworthy, reputable sources of information. So it not only benefits the patients, but it has that potential to improve public health outcomes by just promoting evidence-based practices. Research is also leveraging social media for data collection and recruitment of study participants. For sickle cell, I saw a lot of different CBOs or advocacy groups posting for the hibiscus study, for example. And I thought it was actually an interesting marketing strategy from the pharma, and it makes sense. Like we know the CBOs are always looking for more money and whatnot. So there was a financial mutual benefit to help kind of fund our CBOs who are the grassroots on the ground and really helping our patients day to day while also helping recruit for future studies. Social media really helps reach that diverse pool of potential subjects and be really more intentional with it. Now, with regards to patient engagement, from patient engagement and support, social media provides a platform for patients to really connect with each other and share experiences and provide emotional support. There was a study, granted this was for cancer patients, but it found that 80% of cancer patients used social media to connect with their peers. And the same is likely true for sickle cell, which affects millions of people around the world, but often goes unnoticed and underfunded. Social media helps facilitate that direct interaction between healthcare provider and patients. Maybe you have a patient who is seeking advice and ask questions with healthcare communities on social media. Usually if a patient will comment on one of my posts, I try to respond to all of my comments and direct messages. I usually will just give a disclaimer that this is not personal advice. I can't give medical advice. This is general information. But again, you do whatever your comfort level is. It is a platform, so individuals can share their stories and really humanize the experience. And I think at the end of the day, we have power in numbers. So I always encourage my patients who are comfortable to just share their voice on social media, because at the end of the day, I learned a lot reading the guidelines and in school, but much of what I've learned about sickle cell is just through my patients' experiences. And then I think when they share their own story, it connects them with others who have shared similar experiences. And that online patient community and the support groups can be formed. It fosters that sense of belonging and empowerment. And otherwise, a lot of our patients, I'm sure you get a similar theme where patients are just feeling isolated or ignored. And we know that isolation can negatively impact physical and mental health. Now, for medical providers, especially using social media, can reach a wider audience to raise awareness and share information and connect with others in the community. But by doing all of this, our patients at the end of the day are more informed about their healthcare options. They make better decisions and health outcomes improve. So I started this page because I saw a problem of misinformation, and this was my solution. I'd gone to art school for 8 years. I'm a very creative being, but I really didn't find a way to kind of blend my nerdy brain with my creative until social media came. So this is kind of my creative outlet. And I frequently get messages which just confirm my why regularly. I have people all over the world who are gaining access to information that otherwise was once limited. I've been told by individuals in certain countries that they're only allowed 2 hours of internet a day, and they prioritize those hours to go to my account to learn more about their sickle cell, which is just so heartwarming. So here's just a handful of messages, and it confirms why medical influencers offer more than just education. We validate feelings and experiences while being a voice when they've otherwise felt silence. And we're empowering patients to feel equipped to have partnerships with their providers. I had done a post on bedwetting, and you would be shocked at how many comments I received having no idea it's related to their condition, and people even saying that they used to be hit as a result of wetting their bed growing up. So again, we're thinking about medical trauma with sickle cell, but trauma is not just one single event. Trauma is things that happen throughout our entire life. Some are big T, some are small T's, but you can imagine that a lot of our patients have a lot of psychosocial issues and are going through a lot. And if you had to deal with bedwetting and you were shamed for it when it's literally was made to your because of your condition, you can imagine the mental impacts. People also use it to educate their friends and their loved ones. I do all types of topics. I love doing the taboo topics. So the sexual health one was a big one. And if they're already on Instagram, it's so easy because you can kind of just forward the post, and it's an easy way to start a dialogue with partners and providers. And then I think the most humbling is when I have providers who are supporting me. Or I can keep going and just try to highlight some, but Dr. Powerhays is an awesome sickle cell provider. So it was very humbling when I had providers who are kind of supporting my page and just directing patients as a resource on education. The comment sections definitely get hot, and I do make it a point to respond to everyone. But even if I disagree, since I think it's important, again, to be informed when making decisions and not just doing something because you read it in your Facebook group, but this has been something so much more fulfilling. I used it kind of to fight the information. It was a nice creative outlet for me, but it's the amount of joy and altruistic, just it really does builds me up, which is lovely. So when it comes to professional networking and collaboration, we can use social media just for those purposes. We can share and discuss new research or discuss complex topics. It really is just kind of a new level of networking and collaboration that didn't used to be as easy decades ago. And I feel like I have so many more mentors and colleagues who I can brainstorm or learn from instead of kind of trying to reinvent the wheel in the past. So for the next few slides, I'm just going to show how different providers are utilizing social media. So Dr. Pat McGann, he's the director at the Rhode Island Lifespan Clinic. He does awesome advocacy on Twitter. So September Sickle Cell Awareness Month, like he posts every single day. I love it. World Sickle Cell Day, I'm sure he's going to do something cool. Dr. Amar Zaidi, before moving to the dark side of pharma, just kidding, he still does so much advocacy. So there's just different ways these two use Twitter. Dr. Angela Wayard, the hematologist, she's amazing. She has huge following. She does a lot of beyond just sickle cell. She does a lot of hematology. But this one post is something that really stuck out to me. So I mentioned I do sickle cell, but I also care for bleeding disorders, and the amount of women that I get after having bleeding complications after surgery because they didn't know they had a bleeding disorder. And then they come to me and they have so many red flags that they just normalized, one of them being what a normal period is. So if you have your sister and your mom all bleed for 7 days, sometimes it's the most painful period, et cetera, you might normalize it when in reality, there could be red flags. So here was one post where she's just highlighting what should not be. And you can see there were 2.3 million views. So there could just be, even if just one person saw this and realized, wait, I check off a lot of those boxes. I'm going to go get seen for this. Like that just shows the power of social media when it comes to health outcomes. It's great for research dissemination. You have ASH on here. You have the Lancet Hematology, a lot of people who are posting things. Switching to Instagram, just because that's the typical method that, or I'm going to skip through because it's already almost 9:30, but Instagram is another one that I use, and you have your stories, your reels, your carousel, static posts, IG lives, all different ways to kind of serve your community, and just each topic type you can leverage in different ways. So if anybody is interested in starting a social media account, I'm kind of going to skim through the last few slides just because it's almost 9:30 and I want to give Alex time to present his case as well. But when it comes to getting started, it's a matter of choosing what platform you want. So again, I do Instagram, maybe Twitter is better for you. You sign up, you make a profile. I have two separate profiles. I keep my personal and my professional separate because I just don't want to blur lines from that way, especially if I have any patients and whatnot who are following. I make it very clear to all of my patients that I do not use social media for patient-related issues. If you want to send me reels or a post that you read and discuss it, sure. But if there's any patient-related information or medical issues, always use my email or call me. Just other ways of getting started, which I can share later, but in the essence of time, we will skip over some of these. And I just want to highlight the different considerations. So privacy, obviously we need to respect patient privacy and confidentiality at all times. I feel like this is obvious, but don't share any patient-related information without getting consent. And I would also recommend checking your institution's social media policy because maybe there's other considerations that are included in your policy that might not be obvious. When it comes to misinformation, we obviously want to use our influence to educate and empower. So just if you're resharing a story or resharing a post, check that profile before you reshare it, because there was one post I really liked, went to check this profile, and literally in his bio, he had flat earth there. And I'm like, oh, no, no, no. I can't share something with somebody who believes that the earth is flat. So just be mindful about what you are resharing, because maybe they have one topic that resonates with you, but you look at their profile, if it's with conspiracy theories or other things, it might potentially affect your credibility. When it comes to ethical considerations, you always want to stay professional. This is how we physically present ourselves, how we speak, the type of dialogue you engage in. I try to avoid talking politics and would never personally attack someone, even though there's people who love to attack me behind the screen. But just think about your conflicts of interest as well. So like when I'm talking about different treatments, I just educate on the actual treatment options. It's not like I would ever recommend starting a patient on a product because I have done consulting for that manufacturer. Don't get drunk. I know that sounds obvious, but if you do, like, don't post it on your social media because it can affect your professional integrity. And then you just always want to maintain boundaries between professional and personal. So again, that's why I have the two separate profiles. I follow many patients and vice versa, but there was one instance where my following was kind of perceived negatively and as an imposition. So now I always will check before, because I would never want to make somebody, especially my own patient, feel uncomfortable. And yeah, just don't want to blur those professional lines. How to create content. Canva is the best one. It's totally free. You can also cross-post content. So if you wanted to share a tweet, or there's always these infographics that you can just screenshot and upload very easily. I was going to show a little demo, but they make it so easy to make content where you have different, like I make my own because I like to get creative and just see what type of formats I can make, but they do have pre-filled templates that you can literally click and just change the words yourself. So to conclude, social media really has become a powerful tool in the healthcare field. It allows us to disseminate information and promote advocacy, but it's important to remember that the traditional methods of health education and information still have value, but by blending that old with the new, we can really create a comprehensive approach, and in doing so can help improve patient outcomes. And while this can be a powerful way to reach a wider audience and promote important health messages, it is important for providers to just consider the potential risks and ethical considerations of becoming influencers, and medical providers should just make sure that they're providing accurate evidence-based information, avoid conflicts of interest, and just maintain that patient confidentiality and privacy. So with that, I will end my presentation. Happy to take any questions, and then we can stop sharing. Then we can have Alex come on and present his case. If anybody has any questions, you can put it in the chat, or you can go off mute and just talk. It's a small group of us, so we can keep it personal. And if you're ever interested in starting social media, you can always just reach out to me, and that way I can kind of guide you. But it's not intimidating. It's way easier than some think. I can give you some tools and strategies so you don't have to reinvent the wheel. Yeah. Cool. So next up, we have Alex Cristofori from Johns Hopkins. He is the senior PA at Hopkins Sickle Cell Center for Adults. So with that, Alex, do you want to share your screen to show the case, or what would be easiest for you?
I sent it over by email, but I can also share my screen if that is easier for you.
Give me 1 second. I just saw the email. I can open it now. Okay, perfect. You're all good.
Amazing, thank you. And awesome presentation on advocacy with social media. It's really important. Thanks for talking about that. Okay, so I'm Alex Cristofori. Again, I'm a PA at Johns Hopkins Sickle Cell Center for Adults at the Infusion Center. We have today a presentation on a 32-year-old gentleman who we can call Mr. O. He has hemoglobin SS disease. His date of admission was Friday the 30th from the infusion center with severe vaso-occlusive crisis and rapidly developing hypoxia. He doesn't have any admissions in the recent 30 days. Since being admitted, he's been diagnosed with acute chest syndrome, hypoxia, and has had some agitation or altered mental status, depending on who you ask. He is going to be following Dr. Pecker, although he hasn't established care yet. He recently transitioned his care from Indiana, where he was undergoing the earlier stages of his doctorate degree, and is now transferred here to complete his PhD, and just transferred care to us in the early January of 2025. His current pain is in his knees, elbows, and chest. He has progressively developing chronic leg pain. It's not every day, but it's most days. And he typically uses 10 milligrams of oxycodone at a time. Since he's been with us, he's been using about 20 tablets with fills somewhere between every week and week and a half. He's on lisinopril and rivaroxaban. During his inpatient stay, he's been on Dilaudid with frequent bolus dosing on a PCA with ketamine as well as Precedex for the agitation. He used a pretty enormous amount of Dilaudid, 132 milligrams in the last 24 hours, which is somewhere around 1,500 plus OME in a daily basis, which is compared to only like 100 and change in the outpatient setting per day. He has a history of recurrent acute chest syndrome, no history of CNS insults previously, has bilateral hip AVNs with a replacement in 2018 of the right one. He has a history of DVT-PE, so he's on Xarelto for life. He does not have any issues with iron overload. Hypertension is not an issue for him quite yet. He has an old echocardiogram from before he came to us with a TRJ of 2.29, and I'm not sure if that was inpatient or outpatient, so I'm not sure how accurate it is for screening appropriately. He does have quite a bit of aluminization, but it doesn't preclude him from getting blood. We just need to plan appropriately. So there was a bit of a scramble during this admission. blood that was necessary. And he's developing chronic pain. He has new onset nephropathy in the past 6 months with significant microalbuminuria that hasn't been treated until recent months. And he has recurrent leg ulcers 2 times, not related to his hydroxyurea, as best we can tell. He has no diagnosed history of depression. He has yet to see our psychiatry team here. My indication is not high, but there is some suspicion. There is a little bit of suspicion in terms of aberrant opioid use just because of the frequency and variation in his oxycodone use since coming to me, but that's also in the setting of stopping hydroxyurea, which we'll talk about shortly, so it's a little bit difficult to say for sure. And then I don't really feel as though he's someone who may or may not be using any external sources besides what he's prescribed. He lives with a partner who he's trying to build a family with. He was on hydroxyurea when he came to us in January, or just before he came to us in January. He was on 1,500 milligrams daily, and had a really robust response with an F close to 20. And he stopped that with the goal of family planning as soon as he transferred his care here, and wasn't really interested in talking about continuing it while he was trying to family plan. So we tried to start him on chronic transfusional therapy. Because of insurance changes with the move, there was some significant delays with that until just last month when he was started on simple transfusions monthly, and he got his first. He was transfused towards the middle of April, so about 3 weeks ago, and then he received a red cell exchange upon admission for acute chest syndrome and hypoxia and concern for multisystem organ failure over the weekend, the day after he was admitted. While he's here, his pulses were initially tachycardic into the 140s and have normalized. His blood pressures are 150 over 63. His temperature, he was still fevering as of yesterday, up to 101. On broad spectrum antibiotics. His O2 sats are 95 to 100% on 2 liters, which is an improvement from 4 liters on admission. His baseline hemoglobin is somewhere between 7 and 8 off of hydroxyurea since I've known him, somewhere about around 9 to 10 when he's on hydroxyurea. Most recently, even status post red cell exchange, he's done it at 7.9 with a hematocrit of 25. His white blood cell count is 11.5 from 23 on admission. Neutrophils are 8.2 today. His MCV is 92. Retics are robust in the 370s. And his variant that we have here is from after his first simple transfusion and before he received red cell exchange. So as you can see, he still has 77% S when he's presenting with this severe pain crisis with admission for hypoxia. His creatinine bumped up to 1 on admission, not quite abnormal, but we know that our patients don't really bump to abnormal until it starts to get really bad. So this is pretty atypical for him. And then his T-bilia was up to 10 on admission, now down to 4.6. And he did actually have a UTOX that was done just after admission that had cannabis, fentanyl, and oxycodone on it. I believe that it was after he'd already received fentanyl for a line placement previous to getting the red cell exchange, but I need to confirm that to be safe and sure. He had an initial chest x-ray that was within normal limits on admission, didn't have any consolidations or opacities. And then the following day had a CTA chest with multifocal ground glass opacities, no blood clot noted, and also had a DVT workup in the left lower extremity that was negative with an ultrasound. For pain management while he's here, he's on Dilaudid at 0, 2, 10, and 6, so there's a 2 milligram demand every time he hits it. And then he's also getting clinician bolus dosing for like an additional 10 to 15 milligrams every 24-hour period, unfortunately. He had gotten a lot of IVF initially during the admission, so they've started to limit it because of concerns about vascular congestion. He's insured with Blue Cross Blue Shield private insurance, lives with his partner in stable housing, doesn't have a child or child care, and his transportation is himself. I know that my questions aren't listed here, but Maya, I don't know if you want to summarize the case before we go into the questions.
Sure. So thank you so much for your email. So we have a 32-year-old male with hemoglobin SS, recently off hydroxyurea since their family planning and started on simple transfusion, most recently the 31st of last month. History of blood clot and DVT in 2013, PE, lifelong Xarelto anticoagulation, history of acute chest, AVN with right-sided total hip replacement, recurrent leg ulcers, presented to the infusion center complaining of bilateral knee pain, and he's currently admitted for a severe VOC and hypoxia. also with agitation versus altered mental status on admission and now is being treated for acute chest syndrome, opioid refractory pain, agitation, and pending brain imaging. What is RCE? I'm so sorry.
Red cell.
Don't mind me. Status post red cell exchange for acute chest syndrome. So I was going to say it's a Monday, but it is Tuesday, so I have no excuse. Alex, do you want me to read your questions or do you want to?
I can read them if that's okay. So the first one is, we noted that he had some agitation on arrival, right in the infusion center, and then that concern was expressed. But he was alert and oriented ×4. He got to the floor, and the primary team was also concerned about the strangeness of his behavior. So they ordered a rapid brain attack team consult, and the neurology team came and said he's alert and oriented, and this doesn't seem super atypical for him, so we're not going to recommend imaging of his brain. But he continued to be so agitated that he required Precedex and restraints over the next 48 hours. And, it's hard to say whether or not this is, in our patients, we worry about multisystem organ failure. Sometimes when we see this picture, we get really scared about altered mental status. And, we never want to miss a diagnosis like that because of the fat emboli that can occur and cause ischemia in the brain. But now we're going on 72 plus hours that this man's been admitted without brain imaging while he's still restrained and on Precedex, and we haven't gotten brain imaging to make sure that we understand, although he got a red cell exchange, which is more or less the definitive treatment for that kind of scenario. So I wonder, would you have all recommended imaging him sooner than now, or do you think that, given the assessment with neurology, that we could have waited for whenever the MRI happens to be available, that we can get him in there? And then the second question that I have is, we stopped his hydroxyurea on his behest in January. The delays caused him not to be on simples for 3.5 months, over which period of time he increased frequency of crises and then ended up with this really severe episode. Should he have been placed on simples more aggressively despite the insurance? Should we have initiated him on red cell exchanges right away? Should we have encouraged him to restart the hydroxyurea while we were trying to figure out the transition period, with obvious limitations of patient preference? And any recommendations and thoughts are super helpful for this gentleman because he's complex.
For sure. So I have so much to say, but I want to open the floor to the other individuals here to see if you guys have any clarifying questions or if you have any recommendations. If you had a patient presenting to your emergency room with these symptoms and concerns, what would be your typical management with regards to brain imaging? Would you delay and follow neurology recommendations, or would you kind of take the rein? Feel free to, it's a small group of us, so if anybody wants to go on mute and talk, feel free. If not, I'm happy to fill the air with more feedback. Don't all call out at once. So when you had presented this case, my first thought was like, oh, SHIT, this could be a fat embolism. So if you have a patient who is presenting with severe pain, especially like in the hips, the legs, and Alex, you're saying this, I'm just saying to the group as well, but areas that have large bone marrow, if you have severe bone pain coupled with altered mental status, fat embolism 100% should be one of the differential diagnoses. And I personally would have pushed for the imaging, but the only thing that's giving me some calm is the fact that he got the red cell exchange. So even if they had that diagnosis, it wouldn't necessarily have changed your treatment. So now I would still do it soon. So that way you can say, because if it's already treated, then you might not catch it during that active stage. So I think it's better to do it sooner than later. So you can see, did this guy in fact have potentially a fat embolism that was mistaken for acute chest syndrome? But there's obviously incongruence with what neurology is saying based on the fact that he's being restrained and on Precedex. So I think they're focusing so much on the orientation ×4, but not looking at, which is kind of surprising, at the whole picture, that I would use this as an education piece, because I don't think a lot of providers, even not all sickle cell providers, are familiar with the fat embolism differential diagnosis. So I think imaging now I would, because hopefully you could pick up some, because I've had some patients with fat embolisms that literally look like somebody just took sprinkles and blew them all and it was just scattered all over. So I think that would help potentially guide your treatment options, because if he did in fact have fat embolism or evidence of stroke, then that would probably clue you into going more of the simple transfusion or red cell exchange route for management. Does he have active ulcers currently, or they're just history of ulcers?
Just a history.
I'm curious for the group, like, do you guys always discontinue hydroxyurea for your men before starting pregnancy. Like for our female patients, if somebody is actively planning, like, yes, we'll stop the hydroxyurea. But for our men, we usually won't stop the hydroxyurea unless we're seeing that they're having fertility issues. So I'm just curious, is this something that he wanted, or what the typical practice is out of Hopkins and other centers, if anybody wants to come off and join the conversation too?
Yes, go ahead.
I'm sorry.
No, please go.
Oh, okay. This is Don McCurry. I'm in Kansas City, Missouri at University Health. I do adult care. Most in terms of intentionally trying to get my men to stop hydroxyurea, that's what I advise them to do, but generally they don't. I don't know how many times they come in and say, "Hey, I'm pregnant," or I'm expecting a baby. So I tend to advise them to come off of the hydroxyurea because I thought that's what the guidelines say, but maybe you can tell us different.
So here at Hopkins, for the men, we tend to encourage a consultation for when we ask, like, how long have you been trying? What has your partner done to ensure that they have no fertility problems that are concerning? And then let's get you into a referral with family planning and with urology before we stop the hydroxyurea, and then we can stop it with a solid plan in place to say, like, let's stop the hydroxyurea to see if after their counts are evaluated, their testosterone, et cetera, and then typically we will transition them to some other form of care if we think it's warranted, or we can just go off and monitor them closely. But certainly for this gentleman who has recurrent acute chest syndrome and a great response to hydroxyurea, there's worry that, like, he comes off hydroxyurea and this happens. And so this was definitely not our typical approach, but he sort of self-directed this approach and showed up. And he's a PhD student, so, like, he's a brilliant gentleman, and so it's sort of he's read some research that says the hydroxyurea may be associated with lower sperm counts, and so immediately was like, I'm not doing this while I'm going to be doing my family planning, and so it was difficult to have that conversation. But I think that we tend to be a little bit more cautious usually in this scenario, maybe for this exact reason.
Yeah, so we have a gentleman as well who's family planning, and he has a pretty complex medical history. So we are continuing him on hydroxyurea. However, we basically said, okay, if you've been trying for 3 months, and I always have my fertility 101 talk, because as you mentioned, Alex, it's important to get the health history for the female. Like, we don't want to just blame the person with sickle cell for having issues when I myself had fertility issues. And you really only have 24, 48 hours a month if you're regular to get pregnant. So if you're not timing it right, there's so much to go into having a child, which you don't realize until you're actively trying to have a child, that I think that's great evaluating the partner. So we'll usually have a conversation of just, we'll keep you on the hydroxyurea. If after 3 months and you're actively trying, you're timing it, et cetera, and you're unsuccessful, at that point, we usually will do a sperm analysis. Because I think it's around 91% of patients with sickle cell will have some sperm abnormality, but with hydroxyurea, it tends to be reversible. And I'm very mindful with how I say things, because I had one patient who we took off hydroxyurea because his sperm count was 0. And I basically said, okay, once you stop your hydroxyurea, a sperm cycle has 90 days. So you'll be able to get pregnant in that time period. He ended up getting pregnant like in a month. And I still have the email flagged because it's so funny. He's like, you told me I couldn't get pregnant. So now I'm a little more mindful with my word selection, but I think it's just important that for females, 100% the guidelines and whatnot are recommended to stop it. It's interesting because in other countries, I have heard anecdotally, they'll keep patients on hydroxyurea for the pregnancy because access to treatments, and they do have children who end up being born healthy. But in the United States, we will stop hydroxyurea if you're actively trying. Otherwise, we stop it when you find out you're pregnant for the females. And for our men, we stop it just when we find out they do have fertility issues that are ruled out from other causes, and take it from there. But I do think imaging the brain now, that way you can kind of rule in a differential and see what is called, because you still don't have an explanation for his agitation. His blood pressure is a little high, but it's not like he's having any seizure activities or things like that are contributing. But I would have neurology be a little bit more aggressive because they're not explaining what that cause is. But fat embolism was the first thing I was thinking. Granted, my mind always goes worst case scenario when you were presenting this case. Somebody here said, has he had genetic counseling with his partner as they start family planning?
He hasn't yet. They just saw the family planning clinic last month for the first time while he's been with us. So I suspect that they will go to genetic counseling.
Perfect. And at our center, usually when we have patients who are in long-term relationships with their partner, we'll offer to do the testing of their partner and we'll do the CBC in addition to the electrophoresis so we can try and see if there's any thalassemia trait concern or sickle cell so they can go and informed to their pregnancies. Does anybody else have any questions, comments, concerns? Life questions? Just kidding. Alex, do you have any other questions or clarifications for your case?
No, this has been helpful. I will say that there's an interesting point to be made here that like as soon as this gentleman showed up in my infusion center, I had a bad feeling in my gut about the way he was presenting because he wasn't altered, but he was extremely agitated and very abnormal for the number of times that I've seen him over the last couple of months. And so like I expressed my concerns, but it wasn't enough for me to call neurology here in my clinic because his neurology workup was fine for my physical exam. But you know, he got to the floor and they called them, and then I think that sometimes in sickle cell we know we can sense that our patients are having a more severe event than they are long before there are changes on imaging, long before there are measurable neurological changes in traditional ways, and that sometimes we have to like really advocate and push the envelope because we've seen this a couple of times, and we know that it looks like this constellation of things, even though it's not quite measurable yet. And I think that that's something that we really tried to do here, and it's just gotten unfortunately delayed longer than I would have liked. But yeah, I would encourage everybody to trust your gut when you see patients like this and you're a little bit worried, to sort of just push for and advocate for a more aggressive assessment than might be warranted traditionally.
Alex, I love that you said that. My nursing gut has saved so many lives. And just a fun fact, your vagus nerve is what connects your brain, your heart, and your gut. So that gut feeling is actually biological. So I totally agree with you that we should tune into our gut. There is scientific explanation for that gut feeling as well. And just never let somebody gaslight you, whether you're a patient or provider. If you feel something inside isn't right, just keep pushing and nudging the right people to make sure our patients get what they need. I love that. Well, thank you guys so much. This was lovely. Alex, I loved this case. It was very interesting and informative. We'll have our next echo session. Again, it's the second Tuesday of every month at 9 a.m. for this one. So if you ever are interested in presenting, it's a really non-threatening opportunity to just help professional development. It's only like a 20-minute didactic, and you can do every and any type of topic. We're pretty open. Then we also have a case presentation. So if anybody has any complex cases that they want to get other people's feedback, always reach out to us. The link has the chat box has the link in order to claim your CEU continuing education credits. Otherwise, I hope everybody has a wonderful Tuesday and rest of your week, and we'll see you back next month. Awesome. Take care, everyone. Thank you again, Alex.
Thanks, Maya.
Bye-bye.